Good evening, everyone. Thanks so much, Sheila, for the invite. And towards the end of the day, we're talking about infection and inflammation. I think I should specifically thank Swapnila because, like, probably, hopefully, she'll not interrupt and give me about a minute or two more towards the end of the day. So, when to suspect infection and inflammation in a patient? How do you differentiate between infectious uveitis and a non-infectious uveitis? So, let's see some few clinical scenarios. So there are many situations where we might think it's like probably infection or inflammation, like because these kind of clinical signs and symptoms present both in an inflammatory uveitis, I mean non-infective uveitis or an infective uveitis. So we get confused at many points. So let's start with the most scary one, the hypopion. So when we look at hypopion, so we try to look at the characteristics of the hypopion, look at the supportive evidence of the fundus, look at the glow, look at if there is any other history suggestive of it. This is a similar age of a patient who had a hypopion. The first patient actually had an organizing thick hypopion with a glow which we couldn't make out much of the fundus features. Ultrasound shows clumps and organizing fluffy exudates. Well, the second one, we all know, if we show a picture like this, probably we are dealing with a patient of an after patient presenting with after ulcers who had vasculitis and FFA showed fernary appearance. Okay, so if a patient who has a hypopion like this with organizing clumps and a yellow glow like this, so you are probably dealing with a case of infective uveitis. And in this patient, the history was also suggestive of infective etiology systemically. He had history of urinary tract infection with fever. So this was a case of an endophthalmitis. Well, this patient who had a hypopion of a similar age group, immunocompetent, was a case of a Behçet's disease. Yellow glow in the fundus, as we keep telling again and again, can is seen only in endophthalmitis or in infective uveitis, or something like CMV or a viral retinitis. Look at the glow. If the glow is clearer glow with the synechia like this, you are probably dealing with a non-infectious. A non-infectious uveitis hypopion, such as in Behçet's, usually is a transient mobile hypopion, or in a HLA-B27 associated uveitis, it can be an organized coagulum. So the characteristics are very important. Based on that, you can rule out whether it's a non-infective uveitis or a masquerade, which can even be a malignancy or an infection. So if hypopion, always think infection first, not uveitis. Decide based on history or ocular and systemic features. But what if this hypopion is in an immediate post-operative period? This is a 65-year-old male who presented on the post-operative day with a hypopion. See, always remember, ask for history, whether the other eye had any similar problems. The other eye was uneventful post-operatively. This patient did not have any uveitic history. And when you have operated, you know how much you handle the tissues during surgery. So that indicates whether you're dealing with an infective post-operative condition or a non-infective. But it's not always so easy, because sometimes you can get a patient like this who may be relatively mild course post-operatively in the immediate post-operative period, but can have chronic post-operative inflammatory reaction. This is one patient who was having for about 1 to 2 years. The patient was on steroid treatment. Remember that some of the low-grade infections can have better response with steroid treatment also. So we were initially thinking whether it is IOL related or TAS, but when you look at this PC plaques or these deposits, you are probably leaning towards a diagnosis of a P. acne low-grade late onset end of. ACTAP confirmed the diagnosis in this patient, and this was a case of a P. acne end of, which is a low-grade and late onset. So always suspect infection in postoperative uveitis, especially if it's an elderly or a non-uveitic. And primary uveitis beyond 55, 60 years is very unlikely. So always remember that. And if you've had an uncomplicated surgery and if there is evidence of systemic infection, think of infective uveitis. This is another situation where we always keep thinking this is among the most easy uveitic entities. That's what we think. Scattered KPs, which are so characteristic. We keep showing our PGs and fellows, like telling that this is a spotter, keep giving us the diagnosis. These are fuchs like uveitis, but remember, it can not necessarily be fuchs always, because in fuchs you can have white polymorphous KPs and iris nodules. But if you have pigmented KPs here and there, and if there are some iris changes, this is one patient who had IOP raised, then you're probably dealing with a fuchs like uveitis, which is usually seen in viral. This was a patient who had a fundus picture like this, and ACTAP proved that it was a case of a herpetic panuveitis. when you're thinking of retinitis and panuveitis, where it is not necessary always that you need to do an AC type to confirm the diagnosis, because pattern recognition can almost give us a clue whether it is an infectious or a non-infectious condition. A retinitis or a retinochoroiditis is usually infectious, while a choroiditis can be infectious or non-infectious, something like sarcoid or something or the white Dutch syndrome, which are non-infectious, while TB or toxo can be choroiditis. We are always taught in our generation that the retinal blood vessel and its relation to the lesion will give the clue whether it's a retinitis or retinochoroiditis. And suddenly I realized that we've become quite old when all my PGs and fellows keep showing the OCT and ask me whether it is retinitis or choroiditis. If it is choroiditis, then again, when do you think that you'll have to treat with an anti-infective drug along with the steroids? This is a middle-aged patient. Look at this. These are coalesced lesions, snake-like serpiginous starting from the disc. This is the classical serpiginous choroiditis. Well, this is again a coalesced lesion, not starting from the disc and from the pericuteral region. This is serpiginous like choroiditis. So by now we know that looking at this pattern, serpiginous like choroiditis, we have to treat with ATT and along with steroids, and a classical one we need it in the initial attempt alone. So pattern recognition is important. The phenotypic variant will give us a clue, something like a headlight in the fog or a pizza pie or a cracked mud. Matching the pattern with the supporting evidence, you based on that you suspect the infection, because most infective posterior segment lesions have typical characteristic presentations. So as they say, like if something looks like a duck or swims like a duck, then obviously it has to be a duck. So you don't need to be too very intelligent, try to be over smart and start guessing things. If it's very characteristic, then make the diagnosis. But we are always not so lucky, because you can have patients like this. This was a young adult who was treated with steroids with as recurrent panuveitis and was referred to us last week. Fundus view was hazy. That's what was the records that were showing. Patient was on steroids when he came to us, and he was worsening. With the decrease in vitritis, we were lucky and we saw something yellow like this, and we knew that we are dealing with something atypical. We weren't willing to go ahead with another course of anti-inflammatory therapy. This patient underwent vitrectomy, and there was one clue somewhere here, but otherwise it was looking very atypical. It was not fitting into any pattern. So this was vitrectomized sample showed significant PCR MTB copies, and AFB was also staining. So remember that if it is atypical or recurrent despite adequate anti-inflammatory therapy, then you're probably dealing with infective etiology. And now in this era, this is one patient which you saw day before, bilateral, almost symmetrical lesions in the posterior pole. You know that it's an hematogenous spread. This was a patient who had a post-COVID eye lesions. So anything and everything nowadays, probably you should deal with, you should suspect infection, especially in COVID. COVID seems to be the new infection targeting the immune system. So it seems to be multifaceted. If it can cause immunocompromised like lesions, an opportunistic infection like HIV or AIDS, or it can probably trigger an immune system and cause autoimmune like reactions. So to conclude, you always suspect inflammation due to infection if you have hypopion, if the history is suggestive, if there is persistent post-op inflammation in a non-uveitic eye, in retinitis or retinochoroiditis, and if it's an atypical presentation, and if you have recurrences despite adequate anti-inflammatory therapy. And obviously, if post-COVID, anything you suspect. Sometimes it looks like uveitis, but it's not. So then that's masquerade. That Mudit will tell us. Thank you.